I'm sorry. Yeah.
Well, hello everybody. Thank you for showing up, taking time out of your lunch hour to be here for the CDSS exchange. Is that already a question? I really do.
He's on webinar, so
got to shout over the din
for...
here. Again, though, thank you for showing up. The CDSS Exchange speaker series is really all about increasing departmental awareness of what's going on here in CDSS, also in agency and in outside external work being done at various organizations that impact the work being done here at DSS. We want to give a warm welcome today to Dana Durham, who's coming from Department of Healthcare Services, and she's going to give a little bit of a talk about the Whole Person Care Pilot Program.
Thanks for being here. I know many of you deal with housing, so I'll do quite a bit of touch on that. I do want to talk about our program overall. It's part of one of our waivers. We have a Medi-Cal program, and to do some of our waivers, it's to test initiatives or to see if we want to do things that aren't really part of the overall Medi-Cal program. And one of those that we've chosen to do in a 5-year waiver, they're 5 years, is one called Whole Person Care. And to tell you a little bit about the program, it's the coordination of health, behavioral health, and social services in one place. And the idea is that you coordinate care across the spectrums, because we don't look at people as siloed people. We look at them as the whole person. So how do we take that concept and really deal with people where they are and try to triage all their needs at once? Instead of going, you go here for health, you go here for social services, you go here for behavioral health, because that's a lot of people's experience. And so the idea behind it is to take that experience and coordinate it better. It also does have a housing component, and that often the pilots have chosen the homeless or at risk of homeless community. And in that choice, what we've tried to do is we have housing navigators who work with them to help house them. One of the reasons that's an important component of health is because if you have an illness that has a health component, such as you have diabetes and you need your insulin refrigerated, try to imagine how you work with insulin when you don't have a refrigerator. It becomes very hard. So for several people who are very sick, having their needs for housing is a really important component they deal with. Well, what the pilot entities do is they identify at a community level target populations. And they pick out populations they think are vulnerable and have chronic conditions or at risk for health conditions. And then we did a couple other things beyond that. We have encouraged the entities to share data, because I don't know about you, but getting systems in my world to talk to each other, sometimes it's almost impossible because the platforms don't connect. And so you can have some health information over here and some health information over here. And then you have the HIMSS, which is the homeless management I'm getting it wrong. Whatever system houses the homeless information doesn't talk to the health information. And the social service information, even though they all work for the county, they don't talk to each other. So one of the things that we undertook in this project is we've put a lot of money into data systems that talk across platforms, and also kind of put a lot of money and energy into coordinated entry so that people's needs are assessed all at once instead of in various ways, and answering the same form that has like, what is your name? What are your needs? Do you have social support? We ask all the same questions. And so every time you're working with a care coordinator or anyone else, you ask almost always the same questions. So what we tried to do is centralize that information so it can be updated instead of having to complete it every time. And over time, we're trying to evaluate and see how progress goes on that to see where we get to. I think I hit the wrong thing. The goals and strategies. Our goals are to integrate among county agencies, health providers, health plans providers, and other participating entities, coordinate appropriate access to care, access to housing. Health outcomes are really important. So as we test the project over time, we are the Department of Healthcare Services, and what we're interested in is the theory that when someone is well managed across all of the different parts of their life, that their health outcomes improve over time. And so when we evaluate, that's one of the things we're looking for. As I said, data collection and sharing, targeted quality and administrative improvement benchmarks. So we look at people over years to make sure that they're more well managed. And then finally, we're trying to set up that infrastructure that I talked about within the system. And we want to reduce things such as going to the emergency room at inappropriate times, or that you have to go to a hospital when you need to detox instead of like a sobering center of some sort. So a little bit about whole person care. It's a 5-year program. And it's $1.5 billion of federal funds, and that's matched by each local entity. So it ends up being $3 billion for the 5 years. There's $3 million available annually from the feds. We did 2 rounds of applications. The first round, we got 18 applications. And for the second round, we expanded to, and many of the smaller communities took advantage of the second round. And then many of the counties that are participants increased their footprint and what they were doing in the second round. As I said, the funding is $3 billion overall. Some of the rules in general, that with no single pilot would be awarded more than 30% of total funds unless there were additional funds available. I will say after the first round, LA did ask for more funds because there were more funds available and we were able to give them to them. Funding is based on semi-annual reporting of activities and interventions. It's not really a grant program. So it's a pilot program, and the difference between the two is the entity's invoice for what they do. There are really 5 areas of the budget that they work with. One is infrastructure, and within the infrastructures, there's administrative infrastructure and delivery infrastructure, and those 2 are separate. But we kind of looked to make sure that that wasn't an over emphasis in the budget. So we made sure it was kind of capped at like 20% would be that infrastructure overall. Then we also wanted to make sure that services was an important aspect. And the services are delivered in 2 ways. One is through a fee-for-service mechanism, which means that each service that you get is accounted for individually. And the other one is a per member per month, or we refer to it as a PM service. And so if someone is signed up for a service, they can get some of those services or all of those services or be enrolled in it. And that will enable the entity to draw down funds. But they have to actually be in Medi-Cal. So they have to have a Medi-Cal number to be enrolled in those per member per month activities. Then we have pay for reporting, which we actually pay people for giving us data so that we can have the data we need. We have pay for outcomes. If people achieve certain outcomes, they were able to get payment if they improved by certain amounts. There were incentives that people were able to get. Some of those incentives were pretty interesting. Some of them were about capacity building overall. So can you build up a bank of knowledge within your provider community for HIV treatment, for hepatitis treatment? Some of those things were what the incentives were focused on. And that kind of gives you a glimpse of where things were overall. And as I said, the non-federal share was paid with matching funds from the county who participated. We do have one city, the city of Sacramento, and the rest of the participants are counties. About the lead entities, they can be counties, a city and a county, a health or hospital authority, a designated public hospital, a district or municipal public hospital, a federally recognized tribe, a tribal health program under a Public Law 93-638 contract with the Federal Indian Health Services, or consortium of any of the above. What we found is we do have some district public hospital, designated public hospitals who partner. But for the most part, the agencies that we work with are counties, and those county, we do have the one city though. The lead entities to apply, they had to submit a letter of intent with an application. We had to have one single point of contact. They coordinate with us and they collaborate with participating entities. And those participating entities, there had to be a Medi-Cal managed care plan. In Medi-Cal, 80% of the people we serve are in managed care. So it's very important that we wed the managed care element along with the county or whomever was running the program so that they could exchange and work on data. Oftentimes the providers are in managed care, and when they are, it's important that they are able to be part of the equation overall. Because one of the things that's true about a waiver, and I probably should have said this at the beginning, it can't duplicate anything that's already paid for in Medi-Cal. So one of the things we always work on is making sure that when people can be given to the right entity at the right time, that they're referred and the right mechanism is responsible. Because the waiver's for 5 years, and we want to point people back to the healthcare system and make sure that they're connected going forward. They also, besides the managed care plan, we wanted a health service agency or department, a specialty mental health for the county or the area. That really helped us coordinate the behavioral health, which sometimes, because we carve out what's known as serious mental illness, that coordination really helps make sure that people who have a chronic illness or at risk, often they can make sure that their services are coordinated instead of bifurcated. The public agency or department, and then a really important component is the community partners, because the community partners really oftentimes have the expertise in how to navigate that no one else really has. And what we did have some kind of guidelines for the participating entities. We wanted them to collaborate with the lead entity to design and implement whole person care. So 1/5 of the budget overall for each county went into planning. And the planning really was about making sure that they designed the pilot in the right way, that it met the needs of the community. It's really kind of easy here in Sacramento to go, well, this is what we think you need. But each entity is individual, and making sure that the community itself can speak to the needs of that community was really important. And we felt like the planning from all the partners would be a very important component of that. So to that end, we made sure that there were letters of participation from the participating entity, and that they had a commitment to be part of data sharing. Because as I said before, but I can't say this enough, that kind of dearth of data going back and forth ends up being a huge problem in how things work across entities. So some of our goals for the participating entity really are to increase integration among county agencies, health plans, providers, and other entities within the county that serve high risk or high utilizing beneficiaries. And we want to develop the infrastructure that can continue even after the pilot is finished. So we've, as I said, put a lot of money into the data infrastructure of the county to make sure that collaboration continues after the pilot ends. The requirements are that the lead entity must identify participating entities. Only one of the managed care plans was required to participate, and we have different relationships between managed care plans and in each county. Some counties have one managed care plans. Those are often known as county organized health systems, and there are several counties that only have one entity. Then there are some that have two plans or regional, and those both have at least two plans operating. And then we have what's called a geographic managed care, and that's only in Sacramento and San Diego. And those two counties can have up to 7 partners in managed care. We only mandated that one be participating, but it was very important that the collaboration was there. We did say if a managed care plan participated, they must include the plan's entire network. So if they're delegated, if a network is the providers that participate. So many of you have insurance. In general, you have a list of providers that you get in a provider directory. We said everyone in that provider directory must participate. And if the risk was delegated down, which means that the managed care plan contracted with another plan or entity, that full list of providers must be available as well. If there were exclusions of any sort, we would think about them, but it would be on a case-by-case basis. And the final thing was the lead entity itself cannot be one of the participating partners. So if there was a required lead entity that was the applicant, then they had to get someone else to kind of replace where they were on the mandated partners. Finally, kind of identifying target populations. In general, the pilot is meant to identify high risk, high utilizing Medi-Cal beneficiaries in their geographic areas. But one of the things we allowed flexibility on is to say to the counties, who are your people that are most needy, that you see having ways that you can come up with a strategy to meet that need. And so each of the counties worked to identify different target populations. The target populations were those with repeated incidents of avoidable emergency use, hospital admissions, or nursing facility placement. Could be a population with 2 or more chronic conditions, one with mental health and/or substance use disorders, those who are currently experiencing homelessness, and/or those who are at risk of homelessness, including individuals who experience homelessness upon release from an institution. That institution could be a nursing facility, rehab facility, or prison or jail. So that's just some examples. It could also include the following populations, but with some certain caveats. Individuals not currently enrolled in Medi-Cal, but federal funding was available for those who could be enrolled, not those who couldn't. So if it was an individual who could never be enrolled in Medi-Cal, federal funding was not available. If it's an individual who can be, federal funding can be used if they meet eligibility criteria. Dual beneficiaries, meaning those who are eligible for Medi-Cal and Medicare, are eligible, but they must coordinate with a what's called the Coordinated Care Initiative, where that's applicable. And the Coordinated Care Initiative is a Medi-Cal product line that we have, where we have worked with CMS so that people don't experience two different systems. But the helpline itself works with both Medicare and Medi-Cal to kind of break down those silos. So when a beneficiary or person comes into a system, they experience the same system instead of having to work with both. So the program structure, the administrative infrastructure, which I talked about before, it builds the programmatic support necessary to build, plan, and run the pilot. Some examples are kind of staffing, not staff that delivers services, but staff that runs does the paperwork and all that kind of thing. Program governance, training is a part of the admin infrastructure. Data collection is, marketing materials are, and core program development and support. Delivery infrastructure is what supports the non-administrative infrastructure needed to implement the pilot. Some examples of this are an advanced medical home, the infrastructure that's necessary for a mobile team, community paramedicine team, community resource database, an IT work group that is actually getting the IT up and going, and then like a care management tracking and reporting portal. The two payment mechanisms I kind of went over before, but this gives a little bit more detail on them. The fee for service is that single encounter and you're paid for each service. So things like that would be a mobile clinic visit, a housing transition services, medical respite, transportation, a sobering center, or care coordination. So like if it were a sobering center, they would be charging by the night, basically. So one night would be one visit. A PMPM, it's one or more services or activities that would be delivered as a set to a defined population. That's often that care management, the comprehensive care management. So you can be enrolled in that and you can be in high need of care management, and you may be talking to your care manager every other day, or you may be a little bit more settled. So you may talk to them every other week. It just can be different levels of intensity. Housing support services, those housing support services come in many different kind of bundles. Some of them are getting people ready for housing. Some of them are having housing navigation, trying to help someone find housing. And then some of them are focused on tenant support services, which would be things like making sure that there's some landlord mitigation so that the housing support will work with the landlord to ensure that people can stay in the housing. There's mobile outreach and engagement, and then there's a long-term care diversion as an example of one of the payment mechanisms for the PMPM. Performance measures, go ahead, sure.
So I just wanted to, there does have dollars that are.
So no. But well, let me nuance that. So let me give you a fuller answer to that question. You can pay first month's rent and last month's rent. And you can pay for some of the things that would enable someone to get into housing. However, they cannot pay for ongoing housing. Let me also put in the caveat that it is not a grant. It is a pilot. And what that allowed us to do is to say to the counties, when we pay you for the services, What you do with what we pay you for is yours. Some of the counties have used that for housing pools and other things that enable them to make payments for housing on an ongoing basis, but we cannot use the funding for ongoing housing. Does that answer your question?
Yeah, so there's no restriction to the type of.
There is not, however, it was written into the application what they were doing. Those applications are available online and they were all approved, and we approved them in conjunction with the Center for Medi-Cal and Medicare Services. So some of the ones I described, such as the tenancy support, as well as the housing navigation, they would fall into some of the buckets you just said, but we did work with CMS on all of those to make sure that they were things that weren't duplicative of things that were done and or were allowable. So as with any program, we need to show that we're making movement towards something, and to that end, because if you're doing a program, you want to see if it works or not. To the end, we have performance metrics. And really, the performance metrics overall assess the success of the pilot in achieving the goals that we've set forward. All whole person care entities, they've reported a group of people, a cohort of people, which was from the beginning of 2017 through the middle of 2018, that we used as that kind of initial cohort, off which we got baseline information. And that baseline information helps us to know, as you're working with people, are they starting to use less services? Are they starting to get towards wellness? Are our goals being met? There is an attachment of our waiver that specifies what some of those metrics may be. It's called attachment MM, and it's on our special terms and conditions of our waiver, which is on our website. However, if you're interested in what each county does, they have in their applications the metrics they've chosen, which we had each entity choose metrics beyond that. And since many of you are focused on housing, there are, if an applicant has a housing component, they had to pick a housing metric. And those housing metrics were either that they were housed stably for a period of time, or there are 3 of them, and I don't know the ins and outs of all of them right now, but they're in the applications if you're interested in them a little bit more. So here they are. You can tell I didn't look at this. So the housing metrics are the percent of homeless who are permanently housed for greater than 6 months, percent of homeless receiving housing services in that program year that were referred for housing, and percent of homeless referred for supporting housing who received the supportive housing. The ones that are universal really are, we want to look at how many times you're visiting the emergency department, how often you're using inpatient, what happens after you're hospitalized for mental illness, when does the follow-up occur, and does it occur in the appropriate amount of time, 30 days, is kind of what we looked at. And then the initiation and engagement of alcohol and or other drug dependence treatment. So when is that starting, and how is the follow-up going on that? The programs could pick from this menu of metrics as well, and that menu really is how are you doing at readmissions 30 days after your hospitalization? Are you being able among the population to decrease the amount that someone goes back to jail or prison? How is the beneficiary doing overall on their health? How is the blood pressure looking? The HbA1c control, which is diabetes control, because I only know that because I work in health, but it's a weird thing. And then depression, is your depression kind of maintaining or getting lessened over time? And then your suicidal risk. And these are things that we really feel like help someone overall to have better health. And that's our goal, is to measure better health overall. So with kind of setting up for you what the structure behind the program is, I'm going to tell you a little bit about the applications overall. I've made changes to this, and I didn't change the first part of it. This is all applications. And as I said, in 2016, we approved 18 lead entities, but this is actually all 25. And so we have 10 that have counties with under 1,000 square miles. And those 10 are Alameda, Contra Costa, Marin, Napa, Orange, the city of Sacramento, San Francisco, San Mateo, Santa Cruz, and Solano. The counties that have between 1,001 and 3,000 square miles are Kings, Santa Clara, San Joaquin, Placer, Ventura, and Sonoma. And then counties between 3,001 and 5,000 square miles are Los Angeles, Mendocino, Monterey, San Diego, and Shasta. And then the counties with over 5,000 square miles are Kern, Riverside, San Bernardino, and then what I'm calling the small county collaborative. And that started off being 3 small counties that worked together on the project. So they have one single administrator that kind of coordinates all the administrative parts. That's Plumas, Mariposa, and San Benito. Plumas had to pull out, but Mariposa and San Benito are still active. The pilot size that was targeted for each population, each county, Los Angeles expects to have over 100,000 for their pilot overall. Between 10,000 and 100,000 are Alameda, Contra Costa, Riverside, Sacramento, Santa Clara, and San Francisco. The majority really expected between 1,000 and 5,000. As you can see, it gets really small. Kern, Marin, Mendocino, Orange, San Bernardino, San Diego, San Joaquin, San Mateo, Santa Cruz, Sonoma, and Ventura. And the small ones, which are between 250 and 800 and expected population size, are Kings, Monterey, Napa, Placer, Shasta, that small county collaborative I talked about, and then Solano. So that kind of gives you an idea. As far as who picked what target population, and several of them, as you can see, picked multiple target populations. A lot of them picked those high utilizers with repeated incidents of avoidable emergency use and hospital admissions or nursing facility placement. That was 17 pilots. Many picked high utilizers with 2 or more chronic conditions. Often when that population was picked, there was an algorithm used that was done at the public hospital where they used people who were in the public hospital and then were able to pick an algorithm that allowed them to know who were the most chronically ill and had conditions at which they were at risk for. Several of the pilots chose to work with individuals with mental health or substance use disorder conditions, and that's 15. Often in their pilot applications, you'll see that they have an overall care coordination bundle, and then they have a care coordination bundle that really is geared much more towards the either substance use or alcohol dependence, and there's some that are specifically geared that way. We did have 24 pilots, and there's only one that isn't geared towards the homeless or at risk for homelessness. I would kind of argue the one that doesn't fit into that bucket kind of does, because the one that doesn't fit into that bucket is working specifically with parolees. Yeah, it's Riverside. And Riverside only is working with parolees. Those are people who are at risk for homelessness. Even though they didn't use that kind of as a criteria, it kind of is, because you're getting out of jail and trying to find a place. So Although we say 24 here, I'd probably make the argument that all 25 are kind of geared that way. And in the beginning of their applications, they write out descriptions of their target population, and they'll say how many within their county are homeless and their strategy for reaching them. And then a really important one was those who are released from institutions such as hospitals, jails, IMD, or skilled nursing facilities. An IMD is an institution for mental disorders, I think. Yeah, okay. So that we have 11 that are targeting that population, and those are people who are in transition. And you know, as when you do life transitions, you become a lot more vulnerable. So that extra helping hand to make sure that you're put into a community in a way that you can survive and flourish in that community was a really important emphasis for many of the applications. Go ahead.
Are those we have a program like for 5 that how many people would be money for like
It's a really good question. I don't think it is, but I do have an email box. You can send that question to me, and I know there are a couple articles that are out there that mention kind of this delineation overall, and we're more than happy to reference you or give you exactly who that is.
how are individuals hospitals identifying folks?
Thank you for that question. It really is, it helps me kind of flush out a little bit more of what we're doing. It was each county that picked how that would work. So some of the counties sent specifically discharge planners into an emergency room, and then they would give them a beeper number, and they would beep the whole person care pilot to come and assess and enroll the individual. Some of the enrollment is done through working with a jail system or a prison system. And so they'll partner with the local sheriff, and the sheriff will assess them for eligibility before they've been released from prison. We can't pay for that while they're released from prison, but there is a lot that needs to happen right afterwards, such as making sure that you have the appropriate medication for your condition and some of those things. So that's where the money from the pilot actually goes, is to making sure that as someone's released, that intensive care coordination is done up front. Others are doing community events. So they'll go out into the community and have a community day. We had someone who set up showers. They do screening at the same site. They'll do pet care at that same site. And all of that will get community people involved. So the idea behind it is, how do you find what your specific community needs and what will they come to? And how do you create a way that you address those needs at the local level? So did that answer your question?
Yeah.
So some of the care coordination strategies are setting up a navigation infrastructure. As you know, we don't talk to each other enough. And you hear that from the community level more than anything. Often people will say, well, go to so-and-so, they know what to do, but they don't know how to help you navigate that. So the navigation infrastructure is important in two ways: kind of a coordinated care way of bringing people into the system, and also to kind of help bring up some of that knowledge. There's a dearth in the workforce where people don't know how to navigate the system in their community. So creating some expertise in that area has been kind of creating that infrastructure. A standardized assessment tool that could populate across systems is something that has been very important in some of those counties. The ability to share that data across the various systems. Really looking at kind of some of the social determinants of health and how those social determinants interplay with your ability to navigate the system, and to take those into consideration. There are a couple pilots that have specifically gone towards peer navigation. So they will take someone who has experienced release from jail or has had some serious mental illness and have that person be a peer navigator and work with the person who's coming out of that to, for a couple of things, go, these are the problems I had and I learned how to kind of navigate through that, and also to encourage the person that there's hope after where they've been. Because that person who's been successful helps them to see that there is a potential for something after, which has been very helpful. We had some that used data-driven algorithms, and those algorithms would help them identify who were the most highest utilizers, and so they worked with them first. And that was a really important strategy for a couple of the systems. And we did have some who prioritized those with the highest need, because there isn't a huge workforce. So you take those with the highest need first, and then you meet the needs of others. Sure.
So you had mentioned working with standardized events. You know which will was there a standard
No, it really was specific to the particular county, because somewhat you had to know the resources. Because unless you know what's available, just saying they need social services doesn't help you know what agency to refer to. So often as we've worked on this, we'll find that it's specific to the partners and towards the county, which is they'll start an assessment and it'll prompt them to do something else. And that something else is to refer directly to whomever who can do whatever. And so that local emphasis really kind of helps you get a little bit more at where the need is. So as I've said a few times, the data ends up being what drives almost everything. I'm sure y'all see that too, but if you don't know what's going on with someone and can't share the data, it's hard to offer them help. So some of the ways we undertook kind of dealing with that barrier was we worked with people to expand their existing data infrastructure and framework. We made sure that there really was bi-directional data sharing. So it wasn't that the data went from one place to the other. It went from one place to the other and then back, so that both entities really were able to benefit from that. To kind of tie in some of the health information, because y'all probably don't know as much about health, so I'm going to assume that. And oftentimes we can, at our level, go, this is what happened. Like you got an assessment of some sort, but what that means often we don't get. So you could be assessed for high blood pressure, but whether or not it's actually high, you need to tie in that health information exchange, because that's where that data lies. So trying to bring in more data so that you can serve someone better became an important emphasis. A patient population software, which really kind of looks at social determinants of health, was one of the strategies that many people used. Some people really did a county data warehouse, which enables them to localize all the data within that county so they can share it across social services, across housing, and across health, which is an important component. Go ahead.
We have been trying to keep counties our programs, and one of the things that accessing that data. How did the counties get around? I guess probably not the appropriate, but
No, I mean, it points out a real barrier we came across. Various counties have various interpretations of what can be shared and what can't be shared. So you've got a law that's called HIPAA, which protects patients' health information. Sometimes people will sign a consent form that allows that information to be shared. But even with that consent form signed, there's some other conditions that have further barriers to sharing health information, some of those around substance use and mental health. So what they did was they've only allowed access to certain information at a certain level. So, but even with that, some counties thought anyone having access to the system was too much. So it was really determined at a county by county level, but go ahead.
I was thinking more along the lines of, those who are everybody has that.
We have a lot of counties who are serving undocumented people. They cannot do it with the funding from this program because it is not eligible for matching funds. However, they're using people from the same program to make those connections, but they can't charge it to the program. The places that I've seen that to be true really are probably San Francisco and LA more than anyone else. And I don't know how they've set up those systems, but I do think access to those systems is pretty well guarded. And I'm fairly sure they haven't brought law enforcement onto that system, but I can't say for sure. I know they'd be happy to answer your questions if you want to contact. Mm-hmm. So we have basic data on kind of some of these demographic things and services offered, but and if you, I'll put an email up there afterwards, and I'm happy to send you that. As far as outcomes and metrics, we have an evaluation that we've got an external entity doing that'll be due to us towards the end of this year. And then we will have a final evaluation that will look at how the pilots have done overall and kind of measure that, and that'll be done at the end of the year. But as far as coming up with the data, not yet, but program descriptions, we have that. Some of the services that are out there that kind of tell you a little bit about what's going on are the care management, the wellness and education, housing services, the flexible housing pool. It's not really part of the program, but it's an outgrowth of the program, and post-incarceration services, mental health, mobile services. One of the things, these last two are two that have worked really well as far as diversion from hospitalization, kind of a step down into respite care, which is where you don't have a place to go, but you're not at an acute care level. Where do you go? And these respite centers are a place to kind of go in the interim. And then sobering centers, if you've got, if you need to detox, it's a place where you can go for 24 hours to kind of detox, and you don't have to go into a hospital. And a lot of the programs have gotten those in, and those have been very successful from what I've seen. Here are the resources, and if you have questions, we can make sure that you get a copy of these slides, and or the place you would send questions to is the 1115 whole person care at dhcs.ca.gov, but it's 1115 whole person care, and that's just kind of all one word. Some things that we've seen kind of as far as barriers, it takes a lot to set up this infrastructure. We thought it would happen a lot quicker than it did. So we allowed kind of 1 year of startup. I would say it really took us about 2.5 years to really start delivering the services and the time frame we kind of hoped we would. We're really happy with where we are now, but it's taken a little while to get there. The data exchange, as I said, different counties interpret things differently. So some of the counties who've been more liberal with how they can share information have been more successful than those who haven't. And we just found the partners are really important, and the counties have worked very hard and really partnered to do this. And we're really proud of where we're headed, and we've learned a lot. And I think we'll continue to learn quite a bit. Yes, they usually are. Some of them contract, some of them use county staff. That's been a little bit of an interesting conundrum for them for a couple reasons. It takes as much to hire someone at a county as it does at the state, if not more. And because they only have funding for the first year was setup funding, and the other 4 are the only funding they have for them. So what happens is they hired these people often limited term. To get the position posted took a lot. And then if they got someone good, they wanted to make them permanent. So they end up moving off the program. So that was kind of some of the drawbacks of using county staff, unless you had an exemption from the process. Some, San Diego particularly just uses a contractor for all of it, and it's been really successful for them. Some of the counties who've gotten exemptions have gone really well. I don't think so. I think they're just so different. There are things that they're kind of better at, not. I think that there really is a dearth of people to do the care coordination overall. So you have some issues because you don't have 100 people who are lining up who know how to work a county system. So how do you replicate that knowledge over time? That's been one of the things they've been dealing with and working with. So I think being aware that the work is hard and you kind of have to be flexible, and it's an iterative process, because we'd make decisions and then people would come back and go, have you thought of this? And so being kind of set, but also being flexible was very important in the way we worked with things, because it's a pilot, and knowing that things will work and things won't work. Another thing that we've had to do as we went forward was we've allowed for budget adjustments. And we've allowed them to go, well, this part of the application didn't work, but this part worked really well. Let's switch it out. So that interoperability was really important. I probably would have fleshed out a little bit more the partner participation before we started, because some partners are really engaged and some weren't as engaged. Probably would have wanted a little bit more about how much they were engaged and had a little bit more rules around that, because the ones who have a lot of partners who are pretty engaged, I find to be more successful. And Oksana Meyer's with me. Do you have anything else you'd add to that? So a couple other things I would say about setting up the program from the state standpoint. We've leveraged limited term staff. That has been a little bit harder because it becomes such a behemoth as a project that as you get really good people, you want to funnel them into permanent positions. So making sure that you have some permanent staff on the assignment is very important, because you want really good people, because you want to take these lessons and replicate them throughout your department. And unless you have people who are permanent, it becomes harder to do that, because as the person's term ends, their knowledge leaves with them. And secondly, when we got the applications, we tried to break it into various parts to have different people look at the various parts. We tried that for 3 months. We had this great way of doing it. It didn't give the whole picture. So in the end, what we did was we assigned them out to a person and then had subject matter experts for the various areas. Trying to not do that at first put us behind a little bit, and trying to catch up was a huge part. So I don't know if that's kind of answers some of your questions, but those are the other things that I think of. That's a great question. It can't really be part of the pilot because it's federal funds. However, it has spurred a lot of conversations at the local level. And I know when they have had the conversation, they've kind of gone, we're not gonna turn people away who we come across. So how do we find a way to make sure their needs are met? That's been a lot more successful in counties that have a lot of resources. Like San Francisco has found great ways to go, okay, we can't use this money, we'll use this other pot of money. I haven't found a county who's gone, we have no way to care for people. They've just kind of had to think through the mechanisms of how we make the system work in the various ways so we don't make people vulnerable for deportation. Because if you make people feel like they're at risk of losing what they have, they're not going to talk with you. So that's been conversations that have been had. We can't really make that any part of this project overall because it's a federally funded project. But I will tell you those conversations happen at the local level every day.
I guess the next logical question, what's the possibility of this becoming just with the part will be out?
So it is part of a waiver, and we go through a waiver process every 5 years. So I don't know what the next waiver will look like. It could have parts of this in it. It could not. I will say that the governor's budget allocated $100 million for this project to these particular pilots who are serving those who are homeless or at risk of homeless and have some mental illness with that. So even if the feds, even if we're not able to put it in the next waiver, there's a commitment by California overall to keep some of the lessons learned and to move them forward. And we've talked about how we can replicate some of the lessons learned into the overall Medi-Cal project to improve beneficiaries' health. The end of 2020.
There is not a definite I will continue. How are you guys working with, are you going to the county?
So part of what we've talked about from the beginning is sustainability. And that's one of the reasons we've worked on data infrastructure with them and creating infrastructure that can work beyond the funding of the pilot. So we've allowed a lot of money towards setting up data infrastructure. We've worked really hard for those connections and relationships to be set up within the community. So I think we do things that y'all do, which are we plan for worst case scenario, and we have been working with the counties on worst case scenario, which is it ends, but we also plan towards best case scenario. So we say we work towards best case scenario, but we plan for worst case scenario. So we tell the counties, assume this is going to end. And how are you going to keep these lessons learned? So we have a collaborative where we talk about that and or other things, but we also work to do what we can on the policy level to make sure that the things that really work continue. Thanks for having me.
Thank you, everybody, for coming. Thank you again, Dana, for that. That was a great presentation. We'll have this uploaded to the DSS source homepage along with the slides. Also future information about future CDSS Exchange presentations coming up. They'll be every month. Thank you.